To the Asking Why podcast, our goal is to get to the root issues of systemic problems using a theological and psychological lens. We hope you enjoy. Welcome to the Asking Why podcast. I'm your host, Clint Davis, and I'm very thankful today to have two professors from LSUS. So we have Dr. Dwyer and Dr. McNeil. Welcome, guys.
Yeah, thank you. Thanks for having us.
Yeah, glad to have you guys. So we were talking a little bit before. So could you guys introduce yourself, kind of talk about your position, what you do at LSUS, and we'll start with you, Dr. Dwyer.
Yeah, so I'm Donard Dwyer. I'm professor of psychiatry at LSU Health Shreveport, and mainly involved in research. And research I'm doing relates to the genetic basis for psychiatric disorders like schizophrenia, bipolar disorder. Recently, we've turned our attention to suicide and suicide risk genes, and also interested in the psychopharmacology behind it and the behavior. How does a gene through behaviors lead to the symptoms we diagnose as schizophrenia and so forth?
Yeah, that's awesome. So it's a lot of good stuff we can dive into today for sure. What about you?
Yeah, my name's Dr. McNeil. I'm a psychiatrist. I'm more on the clinical side. So, I guess my main role clinically is treating patients at Louisiana Behavioral Health. I'm the CMO over there. I treat patients on the high acuity adult unit. I see some teenagers in their intensive outpatient clinic. And then at the medical school, I also work as a program director for the psychiatry residency. So I kind of help train these residents, supervise their training over the course of 4 years as they kind of develop and specialize in the field of psychiatry.
That's great. And for people who don't know, I'm an in gratis professor there, so I come in and do grand rounds a few times a year. They want me to come in and do one quarterly is what they've been talking to me about since I guess the students have been enjoying it. So that's kind of what brought this together for you guys listening, that, LSUS is a great school here that lots of people get their degrees at and in Shreveport. And so I love what you guys are doing there and the quality of care and the quality of work that the students are getting to learn. And anything that makes Shreveport better makes me happy. So I really appreciate you guys taking the time to come on here and do this. So tell us a little bit. I would love to talk about epigenetics and dive into all that, but specifically tell us about the trial that you guys are doing kind of with schizophrenia, what brought that about, all that.
Sure. One of the features of schizophrenia that's probably the hardest to deal with is what we call avolition. So the patients don't show a lot of motivation to get up and do things. And of course, you can imagine that gets in the way of their treatment, right? They may or may not take their medications reliably. And so there was a new antipsychotic drug, Adalumid Teparone, and based on its pharmacology and studies that we've done looking at motivation, goal-directed behavior and what are the neurotransmitters involved in that, two that stood out were serotonin and acetylcholine. And this new drug seems to address those pharmacologically differently than a lot of the antipsychotic drugs that went before.
Okay.
So many of the antipsychotic drugs, that the main target is the dopamine receptor. Many of them also bind to the serotonin receptor because those two neurotransmitters seem to be out of whack and contribute to the disorder. And we felt that those two plus acetylcholine are involved in motivational states, maintaining motivational states. And so if you were overactive, as it turns out, with serotonin or acetylcholine, this may dampen your motivation state and cause less goal-directed behavior. And lumateperone is unique because it does pharmacologically address acetylcholine receptors and serotonin receptors in addition to dopamine. So I'm getting too deep in the weeds here.
No, I like it. Yeah.
Anyway, that was a motivation to contact the company and see if they were interested in devoting a clinical trial for this drug and seeing whether it addressed apathy in patients with schizophrenia. We were also interested in patients, apathy is also very common in disorders like depression. And so maybe it would have application there as well.
Now, is that the same with bipolar? Kind of bipolar clients are typically they don't take their medication, they don't stay on track. Is that similar or no?
It can be.
Okay.
So obviously, patients with bipolar are in two phases. Yeah. So when they're in the manic phase, they may feel like they don't need it.
That's right.
When they're in their depressed phase, they may show the apathy and things typical of a depressed patient, and again, not medicate, not follow through with treatment in general, seeing their physician and so forth. So anyway, we thought this might address that better. And the company, which is Intracellular Therapies, they're now bought out by J&J, a large pharmaceutical company, went for the study, and we're looking to enroll patients and see if we get better results with apathy.
So tell me, for you, just on like kind of a human level, why is that important to the average person listening who knows nothing about like neurotransmitters and all that kind of stuff? Like for you as a person, right, as a clinician, we're thinking about people and human beings who we want to care for and make sure they get healthy. So kind of how did that, was there something personal with you that you experienced that, or did you just see it in your work, or what?
Yeah, I guess more in the work, and also realizing the degree to which apathy affects people adversely across other disorders. So we kind of stumbled onto this because there's also an insulin component. Again, I'm getting too deep in the weeds.
No, it's great. I like it. No.
But what you see in individuals who have diabetes...
I like the weeds.
Okay, weeds here. Is that they often are apathetic as well.
Okay.
And they're not treatment compliant.
Huh. Yeah, that's true.
And so that's you talk to people who deal with that population, and they also have 3 or 4-fold higher incidence of depression. And so this is across lots of disorders, and apathy in general. The reason I come at it, as you're kind of asking about, this gets in the way of people living lives, right? If you're no longer enjoying the sports you used to do, and no longer enjoying the friends you used to enjoy, you're not living a full life. And so from that personal perspective, that's meaningful to me to try and see if we can address that.
Yeah, because for so long, schizophrenia and, personality disorders, it's almost like we've seen like, well, they're just kind of hosed. They're not going to get any help. They can come in. And that has typically been some of the clinical kind of response and even cultural response. So getting to get in the weeds and get underneath there and go, okay, this is a clinical issue. It's not always a character issue. How do we medicate this well to where, maybe that'll help them engage in their life and take care of themselves and show up for themselves. And that's huge.
Right.
Yeah.
So those are the motivating factors for me.
I like it. Yeah, it's great. Yeah, because so many times, man, like I said, I worked for the Hub Urban Ministry for a long time, and having people on the street who are schizophrenic and struggle with those things, it's like, you want to help them, but then they don't show up, or they can't maintain it, or they seem like they don't care, or whatever.
Right.
You're the clinical guy. Can you talk to us a little bit about schizophrenia for the average person? Yeah. What creates that? Where are we at in 2026 of like, how does a person get schizophrenia? Is it chemistry? Is it character? Is it nature, nurture?
Yeah.
Answer all my questions.
So clinically, it's a very challenging condition.
Yeah.
If you look at it from a population level, schizophrenia affects about 1% of the population. And of course, it's a very all-consuming disease because the way that it affects the person, it affects almost every aspect of their life. And like Dr. Dwyer mentioned, the apathy means that they're probably less likely to either seek treatment or stay on treatment. So that can make it very challenging to treat. And then, you probably know, but from a therapy standpoint, it's very unlikely that they could really engage with therapy until they're medically very, very stable.
That's
like,
right.
You got to get them on a medication and see some stability before they're, functional enough to really engage with therapy. So I would say that just broadly, schizophrenia has a couple different symptom domains. There are the positive symptoms, which are things, generally speaking, that your brain creates or makes up. Things like hallucinations and delusions. So your brain is making up this content.
And these are voices and sights and sounds and things that are not there, but that you're hearing.
Right. And you can experience hallucinations with any of your senses, any of the 5 senses. But of course, most commonly, we're going to see auditory hallucinations, and then some, visual hallucinations we see a fair bit as well. But then there's the other side to schizophrenia, and some people have no positive symptoms. They don't have delusions. They don't have hallucinations, or at least that it's not the predominant symptom.
Okay.
What you'll notice more are the negative symptoms. So this is where you withdraw. You become more withdrawn socially. You isolate yourself. Sometimes you quit taking care of yourself. You don't bathe as much. You don't brush your teeth. You need, lots of prompting and lots of support in order to accomplish those things. And then you become very apathetic and start to not care about, yourself. or, your relationships with other people. So, of course, the people that have great social support tend to do better because they have family pushing them or friends pushing them to get treatment, bringing them to their appointments, making sure they take their medication on a daily basis. And until the rise of some of these newer long-acting medications, these month-long injections that we can give to patients, and there are some that last longer than a month now. But prior to that, we only had the oral medication. So, it was really hard getting compliance. Taking an oral medication once or twice every single day, the non-compliance rate is about 80% in schizophrenia. So 80% of people don't take their medications appropriately. Now, this new drug that we're looking at, it only comes in an oral form currently, but it has some very unique properties that make us excited. Maybe this will help people that didn't respond to some of the other medications, because that's an issue. People that have tried everything and they just have treatment-resistant symptoms. They've tried all the other reasonable options and they're still having symptoms. So, this medication, has several FDA approvals now. It's a newer medication, but it has approvals to help with first of all schizophrenia, but also some mood symptoms. Bipolar, even depression. Yeah. So that shows a lot of
That's good. That's what I was thinking when you were talking about it. Is like, could it cross over into other diagnoses that are traditionally difficult to get treatment?
Yeah. And then the other thing to consider is the side effect profile. But for every time we make a clinical decision, regarding medications, we have to weigh the risks and the benefits. But for most of these patients, the benefits are going to far outweigh the risks just because of how extreme much this affects their life.
That's right. So how, for the average person, I know schizophrenia is traditionally in certain populations. Can you talk about that? Like which populations it's traditionally in, and then maybe in some areas that people don't actually realize that it's actually more common?
Well, I can say that, because we kind of function, our system functions as a safety net. We end up treating a lot of patients that have either like not the best insurance or even sometimes no insurance. So as a safety net hospital, we do treat a broad range of the population here locally.
That's right.
But especially we treat a lot of the people who are more disenfranchised. And so, obviously because people with schizophrenia often don't have jobs, they tend to kind of hover in the lower socioeconomic range. And so, and there's certain things that predispose you to schizophrenia. There is a genetic component. So if you have, family that's affected by schizophrenia, there's, a higher chance that you could develop schizophrenia. There are also certain environmental things that can put you at risk. For example, using marijuana at an early age can increase your chance for psychotic disorder like schizophrenia. So from a population level, it is important to understand what puts a person at risk and to maybe look at these segments of the population that are underserved, make sure they have the clinical services that they need. Yeah. So that, people don't fall through the cracks.
That's right. Yeah. I mean, you tend to see a lot of homeless, a lot of low income. And so it's kind of like the chicken before the egg. Is it there that that population is predisposed? Have they had generations of people that have kind of lived in socioeconomic poverty, and all of its combinations, come into play?
Yeah, and I don't want to, stigmatize either, because there's some very high functioning people with schizophrenia. There's even a Nobel laureate, John Nash. I don't know if you're familiar, but there was a movie, A Beautiful Mind. Yeah. It's Russell Crowe, and it kind of characterizes. I mean, it really does a great job showing this guy that kind of turned his unique way of thinking into a positive and used it for, I guess, society's benefit. But I mean, I would say that generally speaking, if we wanted to make sure these patients are as functional as possible, it's really important to get medication compliant, get the right medication, but get them compliant with their medications. And that's number one. The best medication is the one the patient will take. Especially for schizophrenia.
Yeah, that's great. So, Dr. Dwyer, what are you currently doing? Y'all are just looking for patients and people to come in and do the trial?
Yeah, we're looking for patients to enroll. They have certain criteria that they have to meet to be able to enter into the study. One being, of course, that since we're looking at apathy as one of the major outcomes, that they have to have. We give them a rating scale questionnaire that assesses their level of apathy. And if they qualify, then, they would lots of other information gathered as well, then they would potentially enter into the study. So, yeah, we're looking to enroll. If people are out there and need to contact us, I think we're leaving contact information in some way or form so they can have access to the study, and the study coordinator can be contacted if a clinician in the area has a patient to refer.
Yeah, that's great.
Family, whatever. We're open to all possibilities.
Yeah. And how many people are you guys taking for it?
The goal is 80.
Yeah.
80.
Yeah.
Okay.
And we'll probably have to screen more than that because, not everyone's going to qualify for the study. But
how many do you guys have now?
I think we have 30 referrals. So we're in the early stages. And
so when did this start?
It's a long process.
A couple of years ago, there have been some false starts along the way. But yeah, we're in a good place now and hoping to get things really rolling.
Yeah, that's awesome. Yeah, well, definitely people listen to this. If you have anybody who struggles with this or you have any sphere of influence, reach out. I'll put all of your contact numbers in the show notes. And, typically it's pretty crazy when we bring the community together and actually make things known, that people are like, oh, man, this is going on. So I'll be sure to tell, our therapist colleagues, my therapists, our offices, but also people that just partner with us, refer to us, churches, be great.
Yeah, thank you. Yeah, we have a website. So it's on the LSU Health Shreveport website. So lsuhs.edu/psych-research.
Cool.
But yeah, if you could link to it, if there's anyone interested, love to, talk with them and see if they're at least a candidate. Because the work that they, as a trial participant, sometimes you are getting early access to a medication or you're getting to use it for a new purpose that, hasn't been explored before, but you're also helping, future generations of people because you're helping us study this medication. You're helping us, figure out what helps, what works.
Yeah. What do you guys kind of see for the average person listening? 10 years ago, maybe we didn't have the same ability. When I refer somebody for medication, for example, unfortunately, most of my clients who get meds, I say, where do you get meds from? And they say my PCP. They go to their doctor. So we've seen a huge shift in this. Can you guys talk a little bit about the science behind doing the genetic testing so that people can know, my real goal is guys, go use the resources so you can make sure the medication you're taking is best for you. Can y'all talk about that a little bit and how that's changed and where we're at with that from a psychiatric perspective?
Yeah, I wanted to come back to something you asked earlier, too, of who winds up with schizophrenia. And Dr. McNeil said, it cuts across all groups and so forth. And that's what the genetics, to bring that back in, tells us, that about 1% of the population is going to wind up with schizophrenia. Now, there are environmental contributors, such as viral infection of the mother during pregnancy, lots of weird environment, but they really are a small fraction of the total cases from those kind of things. It really is the genetics. It's just you deal the cards out, the genes, and at some level, 1% of the time, someone's going to wind up with this disorder. So it can be any ethnic group, any functioning family. You can have 160 IQs with schizophrenia. So it doesn't discriminate in that regard, which makes it difficult. And the other thing that comes back, you mentioned a lot of, you see homeless or unhoused people that with schizophrenia, and you do. And one of the reasons for that is that their symptoms that Dr. McNeil outlined make them largely incapable of looking out for themselves.
That's right.
It takes a lot of firepower to have a job, to manage your bank accounts, right, to pay your rent, all these kind of things. And these are people who are highly disorganized, maybe hearing voices at times, and it's hard for them to manage. So we do see a lot of homelessness in this population because of the pressures of modern society. And so I drifted off a little bit from your genetics, but the genetics tell us
That's great.
that you're going to have this cross populations. No one's immune from it, and it's going to recur at those levels because of the genes. And we don't have a genetic test that tells you. That's the other complicated part. I'm back in the weeds here, but
no, it's great.
There's not a single gene that
I was going to go further. Go ahead.
Yeah, so there's not a single gene that causes schizophrenia.
That's what I was going to ask. Yeah.
It turns out that it probably takes hits at hundreds, maybe even small thousands of genes to wind up coming together in the perfect storm that winds up as schizophrenia.
Mm-hmm.
And so we don't have a genetic test. There won't be a genetic test. People are doing what's called polygenic risk scores now,
Mm-hmm.
where they predict that all these different mutations that are found along sequence your whole genome, basically.
Mm-hmm.
Look for little markers along the way that elevate your risk for schizophrenia, and then assign a score based on all of those. And we're trying to, could we predict? Ideally, just do the thought experiment. Could you have enough knowledge about those different mutations to one day have a score that says, 80% chance? We're a long, long way from there. And I don't think we're ever going to get there. But that's a discussion for another day.
Yeah.
But we don't have a genetic test. We know that genes are important. They're not the only factor. And as I say, it's that genetic environment within the context of living in a complicated society, which causes the real devastation.
It does. Yeah, very individualized, non-communal society probably makes it a lot worse when people aren't being cared for in a home together with their family.
Yeah.
What do you see in children? So are there any signs? So there's a genetic marker situation going on where we can't really fully measure it. We got some general guesses. Children come out right with this kind of predisposition, as you said, in their DNA RNA, and then where do we see this start to play out in children? Is there something as a parent, if they're like, well, doctors, you're just saying it's random, it's just going to happen, that scares me. What are there ways that nurture, or do we see that there's ways that caring for people or not caring for people kind of expedites this?
I don't know that there's clear evidence about, we should do this different, when we're raising a child. I mean, certainly decreasing stress is always a good thing for people's mental health. And what you'll see is that some people, maybe they will go on to have a diagnosis of schizophrenia, or maybe they won't. But sometimes stress can induce psychotic symptoms.
Mm-hmm.
So I'll give you an example. Some people with really severe depression or bipolar symptoms, they can actually have depression, like major depression with psychosis,
right,
or bipolar with psychosis. And it's thought that the stress from the extreme depression or the extreme mania can actually induce psychotic features. And usually they're not as clear as when someone has schizophrenia. So they may not be very persistent, but like some people might hear their name being called, or start to hear voices intensify when they're under high amounts of stress. So reducing stress in childhood, probably a good thing. Suffice it to say.
Toxic stress, right?
Yeah.
I mean, kids need some stress for resiliency, right?
So there's this, concept of eustress, and that a certain amount of stress is good. But yeah, you're right. Overwhelming stress that doesn't let up, and that could potentially be problematic.
Yeah.
So when it comes to psychotic disorders, there's this idea of there's a prodromal phase where we're picking up in some cases on early symptoms,
mm-hmm,
or maybe I shouldn't call them symptoms, but signs that symptoms may soon develop, or signs that a psychotic disorder will develop. And so if you suspect that, I think it's probably good to make an arrangement to go see a professional. And there's even there's a specialized clinic here in town for people with first episode psychosis.
Really?
So once they develop their very first episode, we don't always know that it's an organic psychiatric or mental health disorder at first, because there's other physical things that can actually cause psychotic symptoms.
Right.
A brain tumor, for instance, So the very first time that a person develops psychotic symptoms, we need to work that up thoroughly to make sure that they're not having major electrolyte imbalances, a brain tumor. They need head imaging, they need blood work, and things that maybe go beyond what a primary care doctor would think to order. So, I don't have any affiliation with them, but I believe it's administered through the Volunteers of America. But there's this clinic here called Epicenter, and you can just go online and search for it. But it's a great place to send someone who has a first episode of psychosis. And again, usually these are going to be younger patients. And sometimes the symptoms are subtle and maybe they're not clear yet. But
can you talk about that a little bit? What would it look like for a kid subtly to be having psychosis?
Yeah. Well, we mentioned positive and negative symptoms, but for a lot of people, those negative symptoms are going to develop earlier. So you'll start to see signs of these negative symptoms developing. So they might not be forgetting to shower completely, but they might be starting to neglect their hygiene, relationships. They're starting to become more disengaged, and there's nothing else that explains why this is happening. So
Grades tend to fall off a cliff. That's a big red flag.
Yeah, and some studies have identified, after the fact that we can really determine, we can see these prodromal signs quite early in some people, like, maybe as early as when they're in their single digits, 8, 9 years old. Because, typically we don't really see the development or the diagnosis of schizophrenia until the late teens, early 20s. That's like the characteristic time. There is kind of a bimodal distribution for females. So some women do develop psychosis later on in life, and some males do as well. Generally speaking, the prognosis is much better if you develop psychosis later versus if you develop it at a very young age. But that's all the more reason to catch it when people are young.
Yeah, so we can. That's what I was saying. Yeah,
get on treatment. I know this is kind of deviating a little bit, but I did want to go back to genetics. So although we don't have a way of predicting who's at the greatest risk, there is, a lot of patients may have heard of genetic testing. There are commercially available genetic tests. Now, they don't look at your susceptibility to developing a psychotic disorder, but they can look at the genes that code for your liver enzymes, and they can tell you, either whether or not you're going to be a good metabolizer for a certain medication or bad or a poor metabolizer.
Yeah, that's great.
So it can kind of point you in the right direction as far as picking a medication. And so sometimes that can help you focus your efforts so you don't waste time on a medication that might be suboptimal. And then also for patients that are just treatment resistant, they've tried everything else. Okay, let's go ahead and do some genetic testing to see, what else we can try. What might be worth trying at this point.
Yeah. Is your guys' recommendation to always do that genetic testing before trying meds or what?
I don't think it's as high yield as it could be clinically. Okay. So I would say I do it if I had to say a percentage, maybe 1% to 2% of my patients, maybe up to 5%. But it's useful for more than just psychotic disorders. It usually comes back with a report saying like these are the antidepressants that you're a good metabolizer for. These are the anti-anxiolytic medications. These are the antipsychotic medications. So it has a lot of information on that report. But usually it's just I tend to order it for the patients that are treatment resistant because sometimes they do have to come out of pocket for it. It's a few $100s.
Yeah. Okay.
It's kind of the direction we're going, trying to learn more about why someone's a responder and not a responder. Yeah. We have these kind of data he's talking about, but we'll see more of that in the future, I'm sure.
Yeah, I'm excited about it. It's just people bang their head against the wall, taking the wrong medications and trialing some and figuring it out. And, I'm like you guys, I want people to have the most efficient, direct, option for help that removes the barriers so that the work we need to do works. As a clinician who's practicing every day, it's like people come in, they're on, just a cocktail of medication. And I went to this primary doctor and they told me this, and I went to this person, they gave me this, and, none of it's working. I'm on this milligram. And it's just like, oh my gosh, is there some way? I love that we're moving into this world as treatment teams where we can go, okay, there's some really strong benefits to you kind of looking into this before, working yourself into a bad situation with medication.
Yeah, I wanted to come back to the kids just for a second.
Please.
Because one of the reasons why we don't see more full-blown symptoms at a young age is that the feeling this is a neurodevelopmental disorder. So the genetic contribution causes the brain development to go off course. In particular, the frontal cortex. That's the last thing that gets wired in. Right. And so until that's supposed to be fully functional at a teenager years, young adult, then we don't see the full-blown symptoms because up until then, you don't need your frontal cortex. You need it, but you don't.
It would be nice if my 8-year-old had one.
Yeah, but yeah, right, exactly. It's that top-down control of behavior and that type of thing. And so only does it become clear when it should be wired in and it's not wired in the way it's supposed to, that we see that full set of symptoms. So, yeah, that course is deviating, in someone who's 8, 10, 12 years old. They may be on their way, but it's very subtle picking it up. And that's what Dr. McNeil is referring to.
Yeah, that makes a lot of sense. So because of the prefrontal being the kind of the last thing to grow, and I call it the bow tie guy, it's the part of your brain that kind of tells everything else what to do. And it's like, yeah, until that's mature, then, when you were describing a kid with schizophrenia, I'm like, that's every 9-year-old that's out there. They they don't want to brush their teeth, and they don't want to, it's like parents are like, oh my God, my kid has schizophrenia. But, what you're saying is that if you look back on it, you can see those strong symptoms, and usually without even knowing it, parents could miss those things. And so it's good to just be aware to see, okay, here's a normal range. If you find your kid really, really struggling with these things into their preteen, teenage years, we've got some people you can go and just check in with and go, hey, can we run some stuff and make sure, my kid's not doing what everybody else is. Yeah, kids don't want to brush their teeth, but man, he really forgets. He really pushes back. He's really isolating. His grades are really dropping. Those things happen up and down. But if you have a kid who really has, kind of an overall view of that, it's really nice to know that they could go somewhere and kind of check in and go, okay, is this anything I should worry about? Because they're already doing that. They're already coming to our offices and seeing our play therapist and going, what's going on with my kid? It's really nice to know, okay, well, hey, look, these are all kind of patterning a certain way. What'd you say the place was called?
Epicenter.
Epicenter. Yeah. There's a place that we could go and check that out because then you can really pay attention through the teen years, through therapy, through counsel, through support, set those resources up for them, make sure they have the right community, external supports, accountability, medication, so that then when they're leading into their young adult years where you really start to see the prefrontal come online, and that's when you would start hearing more of the hallucinations and some of the, did you say positive side? It doesn't sound positive, but it's
yeah.
Am I saying that right?
Yeah, positive symptoms. Yeah. Hallucinations and delusions. Which I didn't explain that earlier, but they're fixed false beliefs. People that might, have this unwavering belief that someone's breaking into their house or something, despite evidence to the contrary. So that's what we're talking about.
Yeah. What would you guys, so for the normal person who's like, okay, I'm in this ministry or I'm in this work, or I have a person in my life who is getting treatment. What are your recommendations for people to help people with this disorder and this disease, and what do you see being the most beneficial for them from a relational standpoint?
Yeah. I mean, you want engagement. So, making sure that, you have the providers who care, and that, you're bringing them to a clinic where they're, hopefully connecting with the providers. And then, you don't want people to disengage. And again, once they become an adult, sometimes it's hard to force them into treatment. And that's a kind of a issue that we deal with once their condition gets bad enough to come into the hospital. For some people, it's really tough to get them to engage, and we do have to force treatment on some patients. If it's unlikely that they're going to improve enough to discharge successfully, we might have to force medication while they're in the hospital, in order to get them well enough that they aren't meeting that criteria for gravely disabled. And that is that's one of our admit criteria for inpatient admission, and we don't want them to be as gravely disabled when they leave. We want to see some improvement.
So this is kind of, we're getting into one flew over the cuckoo's nest kind of situation where, people have to be medicated and held down or, given something or.
Yeah. And it's rare that we have to force medications. It's not, I treat high acuity patients, and, I probably do more of that than any other provider at our hospital. But it's still not every patient. And a lot of times once we get a few doses of medicine into their system, they start to, clear up a little bit and then start taking the medicine orally and become a lot more compliant. But, we have this term called insight. We want to help them build their insight into their own condition and how severe their own condition is, and insight into the potential benefits of being on a medication. And, our job, of course, our job inpatient is to acutely stabilize them. Once they get outpatient, then the real work begins as far as like establishing a long-term relationship with this patient, getting them into a clinic where they can start to trust the provider and trust the people that are working with them.
Yeah.
But I think it's critically important to have their buy-in, and building their insight and giving them understanding is really important in that process.
Yeah, it's beautiful. Mm-hmm. It's hard work.
It can be, yeah.
Yeah, I mean, it is. Like most people want to bail on this population of people, and clinicians are like, I ain't dealing with that. So I'm just really proud of you guys for doing the work you do, and because even though it's a small percentage of people, like that's millions of people. So
it's a lot, but it's also rewarding. Sometimes I feel like people that come in with like very subtle symptoms, like mild depression, it can be frustrating because you don't see their improvement as quickly. But someone who's very sick with schizophrenia, I think it's some of the most rewarding work, because in just a week you can see so much improvement.
Yeah, tell me about some of that. What are kind of some of the wins you see that you're currently working with or have seen? Any favorite stories or people that?
Yeah, well, I can't break HIPAA, but
you know what I mean. Tell me their name and social security number. You know what I mean.
Yeah, well, I will say this: that
case examples.
Yeah, a lot of patients with delusions. Again, the definition is a fixed false belief. Sometimes it is so fixed that we can't really get improvement on their delusions. Some people we can, but some patients we don't see that. But we do see them engage more and become more functional. And certainly the patients with with hallucinations, we can usually resolve hallucinations. I'd say in the majority of cases, we can get medication on board to the point that the hallucinations go away. And why that's important? Well, first of all, having these hallucinations is very stressful for most people. There are a small number of patients who enjoy their hallucinations. It's like they have a best friend who lives in their head, and this makes them happy. They don't want to lose that. Some of these patients. But for the average patient, when they have a psychotic break, it causes physical damage to their brain, and they may, we know over time they develop brain changes that are viewable on imaging. They have enlarged ventricles, they're losing gray matter. It's been suggested, I've seen some sources that say you lose up to 12 cc's or milliliters of gray matter every time you have a psychotic break.
Oh, wow.
And I don't know if that's an average, and that's based on some information that I've heard. And I believe it because I know it can be very damaging to go through psychotic episode after psychotic episode. So that's why it's really important to get the medication right as early as possible.
Stop the damage.
Yeah, you're sparing them. For example, if you look at someone, say they're 60 or 70 years old and they've had 20 psychotic breaks in their life, their level of functioning decreases with each psychotic break. So by the time they're older, if they've had just kind of unchecked psychosis, their functional ability at 65 or 70 is going to be much lower than if they got on a medication that worked well for them and they've maintained on that medication over the decades.
Yeah, explain to me psychotic breaks. So somebody with schizophrenia, there states in which they're not having hallucinations and then they start having them and then it gets better?
Yeah, so just like with bipolar and the development of these manic episodes, people with psychosis can go through periods where they're doing pretty well, usually when they're medicated. And often a psychotic break will happen when they get off their medications.
Got it.
But with bipolar, it is a little different because in bipolar disorder, you don't necessarily stay manic all the time.
Right.
So even if you're off medications, you'll go through periods where you're fine, and then eventually a manic episode will develop. But usually in the case of a psychotic disorder, they're fine when they're on their medications, and a psychotic break usually happens when they get off medication.
Okay, so usually they're on medication, they're not having psychotic breaks. But let's say a person's been struggling with this for 60 years, and they've had no medication, no help, no support. They've been on the street. They've been off and on, family helping them, trying to help them. And they just keep having these psychotic breaks. So the psychotic break is the hallucinations and
it's just a flare-up of their psychotic symptoms.
Okay. So they kind of blow up to a higher level, unmanageable, and then they'll go back down and just kind of be at a mediocre state of...
Well, hopefully with treatment, their symptoms.
I'm saying
will
without
get better.
treatment.
Without treatment, we don't always see it go back down like we do in mania.
So they just stay in a psychotic break? Is that what you're saying?
Some people live with their psychotic symptoms, especially if they're really resistant to taking medication. And, historically, looking back pre-1960s, 1970s, a lot of these people were institutionalized.
Yeah.
But with deinstitutionalization came... you see a trend that these people really kind of live either at the hospital, in a jail, or on the streets. I have quite a few patients that's happened to, and some people don't think about what that really means. But I have a patient here recently. Again, I don't want to talk about this patient too much, but there was a big cold snap about a month or so ago, and this patient got frostbite, very significant frostbite, needed multiple, surgery afterwards. And that just kind of illustrates how important it is. Like these patients can't always care for themselves very well, and they're very susceptible. And since we don't really institutionalize people long term, I think it's really important for the community to step up and get these people help and identify when things aren't going well.
That's great.
And we don't always have great mechanisms for that.
That was going to be my next question was, as a care person, and for me as a Christian, like, how do we love people well? And these are the least of these, right? These are the people who are really on the fringes. So I love your push there of like, how do we do that? Is there anything that you guys would love to see in Shreveport-Bossier, advocate for that could help this population?
Yeah.
Any ideas you got how we can solve this?
It's a tricky one. I mean, the more resources that we have, support is important. And many times this population don't have that, whether it's family support and that sort of thing. So, we're not, I wouldn't advocate a reinstitutionalization, but I think we also deinstitutionalized before we were really ready to deal with it.
Well, that's, I think, a lot of things, right? So it's like, where's the middle ground there? We have shelters. Is it educating the shelters better? Is that something we could do, or an option where we, you have Providence House and we've got, the rescue mission.
Right.
Do they just need some equipping? Is there something we could do as clinicians or, ministers or something to go into those places and say, hey, we need you to look for these people, refer them out, send them to LSU because we got a trial going. Like, really, what could we do?
Yeah. Sometimes it is a matter of resources. The Salvation Army, for example, they're great, but if they're full for the night, sometimes a patient with really severe schizophrenia might get turned away and then just be on the streets for a night, which if the weather's good, that may not be the worst thing. If the weather's bad, that could be really terrible. Yeah. I had a patient that happened to recently. He fortunately ended up back in the hospital where we could take care of him. That same, the same night we discharged. So I think it's a matter of resources. It is a matter of, education. And then, a lot of these patients are homeless. So like taking care of some of their basic needs, it's hard for them to dig themselves out of this hole. So, they really need social work and case management. I've heard that around town there's places where they can set up where they can get their mail. I think there's like a Church of the Highlands that I believe I've heard help homeless patients or homeless individuals.
On Olive Street. Yep.
Mm-hmm. And I believe they can get their mail.
They can.
So they can actually maybe start getting bills or pay bills. It's really tough for these patients to do anything with limited resources. And so, programs that help them dig their way out of that would be helpful.
Yeah, the other thing I would come back to is early recognition. Though we said it's subtle in kids, right? It's hard to always spot all the signs and know. But I think, as Dr. McNeil pointed out, if someone goes untreated with their psychosis and they go through more and more episodes, we see this gray matter loss. The other thing, someone learns how to be a schizophrenic, right? They're not trying to.
Right.
But they learn to be very good at that. They respond in certain ways. Their brain changes as a result of that. So the earlier that we can identify someone that's straying off the course and then start interventions, whatever those look like, not advocating medications, but certainly in kids, but making sure that they're staying engaged in things, in sports, education, whatever it might be, church activities, all those kind of things. So those are the, early identification, making parents aware, finding activities for kids, because the better they stay engaged, the less likely it is they're going to go fully off course in a dramatic kind of way. So that would be the other aspect. Yes, for the adults that are already homeless, the kind of things you all just talked about. But I think early identification would be a good thing, good direction to go.
Yeah, that's good.
It's not an easy one because, like I said, it's hard to identify. But there are those red flags that you can see when kids were on the soccer team and now suddenly they're 12, 13, they don't want to play it anymore. And there are reasons why kids go through that.
Sure.
But if they have enough of those, then you might start to think, this is someone, we need to see somebody about this.
Yeah, I think it's super important because you're going to do that. A lot of times we do that anyway, but we're not thinking about schizophrenia because it's such a low statistical likelihood. But to say, well, let's check this out anyway. Let's pay attention to this for more people to know this could be the potential future or at least part of it. I mean, I think that's really, really important to know, for clinicians, for anybody who's working with kids. I was thinking about, Boys and Girls Club, just so much of this is just, you guys know this, but it's like nobody have no basic training on mental health. We don't get this in school. You know, we don't learn it as teachers. You got all these systems that are caring for human beings, and none of the people who are in charge actually understand anything about how the brain and the body works, especially in children. I did a keynote in Lake Charles last week out of this huge social working thing, and that was my main thing is like, let's all slow down and simplify again and get back to like really looking at kids as human beings and not just trying to modify their behavior, but really try to understand them and see them. And then we might catch some of these early signs of ADHD or anxiety or now schizophrenia or whatever the thing is. And I think connection, which is what you're describing, is such an important cure for so many of our mental health problems early on. Not that it won't continue to be a struggle, but if children are connected to parents and feel safe and feel seen, then, you know, it does help, you know, in the future of their symptoms being
Absolutely.
less traumatic.
And the more engaged they are with counselors, with whatever, teachers, the less likely it is that they burn those bridges as they do when they're going through these psychotic breaks.
That's right.
Right? That they have someone they can lean on, or they have that past history that they can kind of go back to. If, I was connected before, I can do that again.
Yeah, they've experienced it that they can kind of, you know, jump off of. Yeah, it's great. What else? Any closing thoughts? This was great. I really enjoyed it.
Yeah. No, you know, again, it's schizophrenia is one of those all encompassing kind of disorders. So, you know, I'd say that patients that really suffer sometimes, and you know, they are maybe a higher risk for self-harm and substance use, and so these are other problems that we think about, but they're interrelated. So a lot of other issues that we see in mental health are interrelated. So it's important to attack the root of the problem.
Yes.
And of course we don't have the perfect tools yet, but I mean, every year more medication options come out. The work that you can do as a therapist can be very impactful. And like I said, if the patient is medicated correctly, therapy can be that much more impactful. And then of course families need to remember that they need support, and they don't, you know, sometimes it's hard not to take things personally or to maybe feel like giving up on somebody. But, you know, I think it's important that you help a person find that level of support. And if they don't have it, maybe help guide them in the right direction.
Yeah, I like that. That's good.
Yeah, I would just end with a message of hope, right? That people like us are out there, you know, Dr. McNeil treating these folks, trying new drugs, medications that may help out. People like me are out here doing research, trying to figure out what's going on, maybe come up with new ideas. So it is a time of hope. There's, you know, this is the best time in the history of the world to have schizophrenia.
Yeah. I'm very encouraged by this conversation. I mean, I think people, you know, can get so negative and see somebody that has this and go, well, they're just stuck that way and there's no hope. You know, and then you know, the apathy that the schizophrenic has, it feels like the culture then is apathetic to them. Mm-hmm. You know, I think that's an interesting tie.
Infectious.
Yeah, it's infectious. So I think, you know, love to me is something that we can all give to other people and really care and wake up. And I think these conversations are really beautiful for our community. Go, okay, wow, I didn't know any of that, which I think most people will say when they listen to this. And then ask yourself, like, if you're listening to this, what can you do? You know, where your church, your mosque, your synagogue, whatever it is that you're pouring into in your community, how can you give money? How can you pray? How can you give time? You know, it may not be it may just be a little bit, but if a few people do a little bit, that's a lot. And I do think that if the different shelters and the different ministries could hear this conversation and really understand, it makes a huge impact on these people. Mm-hmm. And there is a group of people who can care for them. There's medication that we're coming up with that can lower those symptoms and keep them from having psychotic breaks. They can actually function and be connected and contribute to society. And they are suffering, right? Mm-hmm. Just because they're having a break and they are hearing voices doesn't mean they're not a human who's suffering. And I think sometimes people can feel like, or they'll say they're just crazy, as if crazy means I'm not a human and I don't have anything going on that, you know, sucks.
Yeah.
And it's like, no, they do. See them as humans. Like, stop dehumanizing them. And anyway, I have a soapbox about that all day.
Yeah.
All right. Well, thank you guys for coming on, and we'll put your stuff in the show notes. yeah, anything we missed or that y'all want, like if the world's listening, you want them to know?
I mean, I think that covers it.
Yeah, good.
Don't be persistent. Be persistent in trying to get the help that you need.
Yeah. Well, man, I'm super thankful for both of you and the work you're doing. And I know the clinical work, working with therapists, as somebody who has a bunch underneath me that we're working with, like keep doing good work, man. You're producing good people. And when I come get to do ground rounds, like they're asking great questions. They seem really clinically sound. They're always staying after and talking to me about some of that stuff. And we just need more help in this field as the world continues to, kind of change technologically. Oh, that's what I wanted to talk about. I knew there was something in my brain. Can we talk about AI for like 5 minutes and y'all's perspective on, this population? Because what we're seeing is like lots of breaks from people using AI is what I'm hearing. I don't know if that's real or if that's just, social media popping off, but what do y'all think about all that?
I don't know that I've seen data on, AI inducing a psychotic break, but I do think that AI, what the context where I've been hearing AI come up. In fact, I was just at a program directors conference here recently, and of course, AI is creeping its way into medical education. So we're looking at AI as kind of a companion right now for helping us complete patient encounters. Like it's going to help kind of listen in as we're talking to a patient. It'll complete the notes for us. But the next evolution or the next step of AI beyond that would be as kind of a clinical support tool. So I could see a future in which AI has a role, in the near future, where AI has a role in helping you think about different options. So much in the same way that genetic testing would inform you that, hey, this medication might be the best choice for the patient based on their genetics. I think that AI could maybe scan a patient's whole chart and have a list of very relevant clinical options based on the totality of their clinical chart, which is something that one provider is not going to be able to keep in their mind necessarily, unless you know a patient very well. You don't know everything that's in their chart, even if you just reviewed. Some of these patients come in the hospital 10 times a year, 20 times a year. So, it could, in an instant, scan 10 years worth of data and tell you these are the clinical options. These are the next best steps. So I could see that happening. But as far as AI or the consumption of AI content predisposing you to psychosis, I haven't heard that yet. Yeah. But I'm gonna start looking for it now.
Yeah, well, the thought of like somebody who's on the edge or on the edge of a break or really having a hard time and stress, and then they get on there and it becomes their friend and they're talking to it, engaging with it. That's some of the things that I've been reading about and seeing from clinicians is just then people thinking that that's a real person and getting lost in the relational attachment to Sam or Fred or Ashley or whatever they call it, and now there's all these apps for AI companions and, sexually, emotionally, date wise,
therapy, AI chatbots.
Oh man. Yeah. Last week I had a guy on talking about OCD and I can't remember the name of the AI they've created, but it's a platform that allows you to go on there and in between your sessions and he was talking it up, but I was kind of like, oh man, it makes me nervous. It's like, I love I can summarize these charts and kind of put you in a thing, but man, how dangerous is that to swing out of actual relational human connection? And
I'm not a fan.
That was
it's you think I might be the techno guy in the lab, thing, but I'll remind the A in AI stands for artificial.
That's right.
So it's not actually intelligent. I can't tell time, right? I can't reason. So we're over relying on it because we don't understand it fundamentally.
Yeah.
So it's great at crunching numbers, like you say, charts. That's what it does. That's what it was invented for. But it can't reason, right? And so any kind of relational thing, if you want to be in a relationship where there is no reasoning, you're in it with an unreasoning being, then that may be for you.
Yeah.
But otherwise, I'd stay away.
I love that. Yeah, it's so true to remind people what the A is. Yeah, it's artificial. It's fake, And again, I'm with both of you. I think we're both all saying the same thing. It's just going to be how quick this is happening. And I don't know if you guys feel it, but as a clinician, 4 months ago, we weren't asking, is that video AI or not? Right. And now, I'm like, how many times can we ask this? And I feel like my hope is, this is my hypothesis, I'm really hoping that AI destroys social media. So the reason is because if we get to a place in the near 6 to 8 months from now where people go online and even the internet and they're watching a video of Trump, or they're watching a video of Iran, or they're watching a video of, policing, or whatever the stressful thing is that everybody consumes for whatever reason, that they go, I literally, right now we're still asking, is this AI or not? I believe by December 2026, the technology is going to be in a place where there's no way we can tell the difference. Because just in 3 months, it's boom, 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 changing. So by December, when we get on the internet, when somebody gets on Facebook and, somebody starts scrolling, right now we're kind of freaking out about videos and then realizing, oh, that's fake. But by December, we won't be able to know. And so my hope is that people go, what's the point of being on here when everything that's out there that I'm consuming that's not real human connection, I don't know whether it's real or not. Y'all see where I'm going with that?
Yeah, and I could see people trying to disengage from technology, and I did see something recently about how analog is coming back. People are wanting more analog experiences.
Yes.
And if they could disengage from social media, and then because they're so just kind of fed up with the direction it's going, and then choose real human connection, and
there it is.
And we could go that direction. I think that would be better for mental health.
Yeah,
I think so.
Yeah, for sure.
Yeah, good. Yeah, that was I was putting that in my brain because I wanted to hear y'all's opinions about it. Because I do think that in the field of psychology, working with real humans, not artificially, but actually connecting with people, it's like we have just lost that so much in the last 14 years. And it seems to be imploding on itself. It seems to be that we're aware of it. But much like cigarettes, people are still, it's like, oh, this is going to give me cancer, but we're still token away at it regardless because of our pain and our lack of disconnection. So if we can have real relationships and real connection, subvert the artificial ones, I think we'd be a much better off society, and it would really affect our mental health in a positive way.
I think it's a great point. Yeah, we're made for connection.
That's right. All right. Well, thank you guys for your time, and thank y'all for listening. God bless you guys, and have a good week.